Thank you. Any question to Kim? Do you have a question?
No.
No. Thank you, Kim. So the next speech is from Hamid Abbasi, lateral approach.
Good morning. Thank you for the opportunity. I'm going to talk as well about the transcameral approach, oblique lateral posterior lumbar interbody fusion. I'm just going to start here. I need to give you a little presentation about the background of this. Spine is #1 reason for disability in the United States, but now as well global. Why is it important? Because as a matter of fact, when you are 70 years old, there's only 1 to 2% chance you don't have a spine problem. We don't need to do surgery for all of them, and so many of them we can help with decompression, but a small group of them need fusion, and that number is tremendously increasing. As a matter of fact, this is from Becker Spine. The number of the spinal fusion, instrumented spinal fusion in the United States is about 1.6 million. This is a huge number. We have to become more efficient helping these patients, and as well, this is a patient we can help. There's a huge group of patients that are borderline, have comorbidities, but we cannot help them. MIS is not about the skin incision. What happens under the skin is make MIS, that you don't have to cut the muscle and turn them into scar. These muscles are multisegmental, that you don't disrupt the autoregulation of the muscle. You don't disrupt the vascularization of the bone. As a matter of fact, in the traditional cliff and TLF, you're reducing the vascularization of the bone to 25% of the original value. Imagine how much damage we do there. This is a patient of mine. In 2012, 2-level TLF. In 2014, 1-level adjacent segment OLLIF. In 2015, patient had a car accident. I took the patient back, and you see where I did the TLF, it's scar. Where I did the OLLIF, it's pristine tissue. You can imagine this patient recovered much faster. This is as well a patient of mine. 1-level TLF. In the area of the surgery, everything is scar. Even 2-level above, multifidus muscle is scar. And we have good indication now that with MIS, you can reduce the rate of adjacent segment disease. That study will be published soon. As well, efficiency is important. You remember 1.62 million of these surgeries in the United States. Every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. Let me repeat that. If we are not going to rush the surgery, we are not going to cut corners, but if you can cut only half an hour from the surgery with efficiency of the surgery itself, you are saving 17% on the risk of the surgery. So practically, if you can reduce the time of the surgery under 2 hours compared to above 2 hours, you have half the complication. Now, why is it important? For many of these patients, when they are borderline, the time on the anesthesia itself a risk of the surgery. Now, if you don't take anything from this presentation, take this out. Especially in elderly, do your best to provide to the patient, no matter what, a surgery that you can perform under 2 to 3 hours total anesthesia time. That has a huge factor on the outcome of the surgery itself. Now, let's talk about what this approach is. This approach is transcameral, but with some modification. We published as well a paper about that. You can do a true prone lateral transpsoas approach with the same instrumentation. There are different names for that, but more or less we are consolidating the names. If it's truly transcameral and you do a full endoscopy, we call KLIF, and if it is without the endoscopy, and the 2C arm and neuromonitoring, then we call it oblique lateral posterior lumbar interbody fusion, OLLIF, which is distinct from OLLIF ATP anterior to psoas. Indication, if the efficiency is the point here and your priority, this is nothing really beats that. If direct decompression is needed, then obviously you have to do traditional surgery. If lordose is your priority, you have to go anterior to put a huge footprint cage. The information I'm giving you is not based on 30 cases or 100 cases. It's based on, as of last week, 2,085 cases. This slide is a little older. And 95% of the surgeries can be done under 2 hours, total anesthesia time. This is a typical day in my practice look like. But more important than that, is that these patients mostly are discharged within 24 hours. I do that in a surgery center, and most of these patients within weeks are back to their life. This is a study that shows the effect of the BMI. The blue line is a regular TLIF, the red line is MIS TLIF, and here you see at the BMI of 37, actually MIS TLIFs become more difficult. Whereas the transcameral approach can keep the edge up to a BMI in this study 40, but then later we proved that even BMI above 60 can be efficiently treated. 96% of these patients ambulate within the first 24 hours, and this is updated about the whole profile of this surgery. We have published a paper. I'm not going to bore you with that, but compared to open surgery, where the acceptable risk of the surgery with the infection is 3 to 5%, here we are talking 0.24 superficial and only 2 deep infection after more than 2,000 cases. So, this is a correct presentation of our profile of spine surgery. There is a huge group of patients in the United States we cannot help with a good conscience. Elderly, comorbidity, high BMI. As a matter of fact, we recommend not to do elective surgery with BMI above 40. What you see in the future is currently my practice. I can help more patients, but many of them I can help in the surgical center. And you don't need $1 million O-arm, or robot or navigation machine. What you see on this picture is all you need. Let me repeat that. A handful of instrument and training is all you need. This is literally the interbody tray look like. It's not crowded. You can do it in the minimal kind of setting. We went through the anatomy of the cambium triangle, so I'm not going to bore you with that, but this surgery with this efficiency can be done only with 2 CR. We have protocolized it, meaning that connect to me or go to our AbbasiNaSociety.org, you will get a map of everything that's needed for this. You don't have to make your own. You can gather your own experience, but as well you can just share mine. We mark as well the AP and lateral center of the disc, and then we just take halfway between those 2 lines that we connect. We use a neuromonitoring probe. This surgery cannot be done without it. The neuromonitoring helps us to get to the cambium triangle without being too close to the nerve. Then a K-wire goes in, a dilator goes in, a tube that is 8 millimeter inside, 10 millimeter outside goes in, and a series of tubes are used to do a good discectomy. And you can do a fantastic discectomy. The learning curve is 20 Ks or 40 levels, but realistically for the first 5 to 10 Ks, you need somebody with you to walk you through it, okay? Doing it alone is really nerve-wracking. So I would like to run the video just for 2 minutes. So while we are starting the video, before we do that, that will be my last thing. Let me just show you that you can, little by little, once you get good at it, you can make this to become this. You can put the cage anterior, posterior, right and left for correction of deformity. This is how skin looks like, and this is surgery was done under 2 hours with a cup of coffee blood loss. All of a sudden, you can provide this to patients that had been rejected, but by 5 surgeons, because this would be just too dangerous for a patient with an ejection fraction of 35. Or you can help a patient like that, certainly not your first case, but a patient that literally has been as well rejected for good reason, with a performance, again, under 2 hour surgery, barely 50 cc of blood loss, and the mother is smiling and crying because after 6 months, the son could finally walk. So I like to run a 1 minute x-ray of the procedure itself. Connect to me or Amanda sitting in the 3rd row there. We give you all the information you need. You don't need to reinvent the wheel. The car is protocolized, it's there. We are happy to share with you all our experience in a very condensed form. Can you please share that? So here you see, first of all, I marked the center of the disc in the AP lateral. Then, first thing I do, I put a Jamshidi in one of the levels and get the bone marrow I mix that with my biologic, which truly increases, there's a protocol for that as well, we give it, share it with you. We mix it with our biologic that really increases the rate of fusion. This is the probe. I keep the trajectory with the K-wire, I dilate. The next step is discectomy, preparing the end plate. Again, these are very specific tools. Catch me, I will show them. I have them with me. I will show them, and then pack it with biologic, put the cage in. And what you don't see here, that we started this surgery at 5:20. Right now, it's 5. This is, this is, or 4 something, but practically from the beginning of the surgery to the end of this cage placement is usually between 7 and 10 minutes. And the total surgery for 1 hour fusion is usually 35 minutes. This is the average time. And if you can now scale it, help one segment and move on, all of a sudden you can be extremely efficient and help a lot of marginalized patients. So I'm going to stop here. I mean, the rest of it is just percutaneous instrumentation. I'm not going to talk about that. Well, thank you very much. That was my presentation. Thank you.
Amit, very good presentation.
Thank you.
So, go ahead.
Not as experienced as you in that technique. I'm just starting to develop. It takes me 1 hour to do whatever it takes to do half an hour, but still, I'm catching myself that I'm offering that type of surgery easier and to more people. Is that what you see as well?
So let me tell you, first of all, if you walk out of here and you think I'm a fantastic surgeon, you wasted your time. If you walk out of here and say there's a new tool I can add to my toolkit and I can learn it faster than Abbasi, then you got the right message. As a matter of fact, it took me 200 cases before I fell under 1 hour for one-level fusion. Everybody who follows our protocol, after 10 to 12 cases, we have a good study in that. Everybody who follows this protocol falls after 10 to 12 cases under 1 hour. So your experience is right at par that, you know, and you don't try to be fast. You just let it take its course. And that's the experience that other people as well have shared. They get 10 times, 7 to 10 times faster than me with the same numbers. And that's the experience I want to give you. Okay, thank you very much.
Are there any other questions from the audience?
I'm happy to answer any question.
So do you offer this surgery to more people because it's faster?
Well, not because it's faster, because it changes the risk versus benefit ratio.
Yeah.
Definitely, fast is not the point. It's about that if you lose on somebody with a ejection fraction of 35, 37, if you put them on an 8-hour surgery with 1.5 liter of blood loss or 1 hour surgery with literally 100, 150 cc of blood loss, that is really what makes it different. That you can all of a sudden reduce the risk associated with surgery, and you can give an 85, no, let me be very clear. You have an 85-year-old patient, marginalized, and with a good conscience, you cannot give them the option of the surgery because they won't really recover after your 8-10-hour surgery. Now, what is the consequence of that for that 85-year-old patient that cannot walk? Within 6 to 12 months, the condition, you push the risk outside of your practice, but you didn't help the patient if you don't help them to ambulate. Now, all of a sudden, with a reasonable amount of risk, you can mobilize them and keep them on track and keep them mobilized in the last 5, 6, 10 years of their lives. Now, in that specific group of patients, really nothing beats the efficiency and change the equation as much as this approach.
Thank you.
Thank you very much.
So we close the session. Thank you very much.